Good morning again. A short segment, proximal tibial fracture, how to ensure reduction. That's a really pain in our environment and in every operating room. And I'd like to share with you in the next minutes to better understand the problems related to the nailing of proximal tibial fracture, to discuss the specific anatomy, realize the dislocating risk factors, which are many, and understand the role of the starting point, and learn about various options how to ensure reduction. When we look at the data related to malalignment and instability, in the tibia, we find little in the midshaft, a little bit more on the distal, but heaps of literature distribution of muscles is very eccentric. Almost everything on muscle is on the lateral side and posterior, but there's nothing on the medial side. This also favors the development of a valgus deformity. The third thing is to understand tibia eccentricity. We very clear have in mind that the femur is an eccentric bone, but we don't have it in mind so much for the tibia. And when you look at total knee components, you see, let's say, address the eccentricity of the proximal tibia. And this is also supported by this very old anatomic study where they retrogradely reamed the tibia upward, and they looked where do they exit. And in 75% they found the exit in the lateral part, lateral to the lateral tibial spine, in 25% in between, and in 0% on the medial to the medial spine. So this eccentricity has to be kept in mind when we do plan our starting points in order to avoid deformation. Number 4 is to understand the tibiopatellar topography and its implication for skin incision and bone starting point, for the nail canal, the alignment and stability. On the left side, we see when we start with this transligament approach, when we come too deep, then we end up posterior, and we end up in this with a high risk of translation anterior to posterior. So it's important that we start, like seen on the right side, very, very steep in order to hit the medullary canal and to avoid this anterior-posterior translation risk. Another anatomic consideration to make is the bone is not equally distributed in the transsection, in the transverse section of the bones. There is a lot of bone in the anterior edge, but there is very little posterior. So when we start placing the nail posterior and try to work it more anterior, this is very difficult because the bone is compressed in the anterior edge. While when we come very, very steep right from the beginning, it's easy to correct it posteriorly, but it's always very difficult to corrected from posterior to anterior. And number 6, understand the eccentricity of the shaft cross-section. When we are planning and guiding the starting pin, and we reference to the anterior tibial crest, many assume this is the middle of the medullary cavity, but it's not the middle of the medullary cavity. It's actually the medial border, and the center of the medullary cavity is always a little bit medial of it. So these are all factors which should be considered in order to find the right starting point. And as a general rule, in all sorts of arm nailing, is skin incision defines starting point defines alignment. I never understood why for a 10 millimeter implant we need to have a 10 centimeter incision, where when it is placed in the right place, like in this example. Careful planning, you see here a little K-bar, which represents the center of the medullary cavity. And once you follow these planning rules, you end up with a thin skin incision, which is almost like a locking bolt size. Pros, in the meantime, in the last 20 years, a couple of other approach options have been developed. We have now the suprapatellar approach, the parapatellar approach, the transligamentous approach. But as you see on these images, the knee really doesn't like to be entered with such huge devices, and I always have difficulties understanding which always shows zero problems in relation to the cartilage damage, as you see it on the lower right image. So what instruments do help us for the management of short segment proximal tibial fracture? Distractor can be very helpful. Core-linear bone clamp, as we see it here, for reduction, shunt screws, and a T-handle. Other instruments or concepts like this X-fix frame, the so-called clothesline technique, which puts a wire proximal, one distal, and spans it out and gives gross alignment and temporary stability for the nailing. And additional implants also very helpful. This distributes the task between nail and plate. The plate is responsible for managing translation and rotation, while the nail is defining length and addressing the compensation for bending. Polar screws have played a major role in recent years. Like we see here on this segmental fracture, it doesn't look like a difficult fracture, but when we see the postoperative result on the right side, we see instability, we see malalignment, and when we analyze the problems related to this, we find that we have a large medullary cavity and a small implant diameter, so we have a contrast between these two mechanical parameters. How did we deal? How can we deal with these problems? We temporarily remove the nail of this unstable fracture situation. We block this old nail path, which is still visible on the picture on the right side. We block this old nail path, redefine the starting point, and now when we re-enter the nail, the old nail path cannot be used anymore, and we all of a sudden have a nice alignment. We do distal locking first and then back slap and have a fantastic adaptation. We have a fantastic alignment, and we have a significant increase of stiffness of the entire construct, and we have, as a result, a very sound healing, and all achieved with a very simple $10 implant, which needs to be placed on the right spot. Here, for comparisons, a preoperative situation. So these tiny little things can make a big difference. What is the problems in metaphyseal tibial fractures with arm nailing? We have three problems. We have a diameter discrepancy between nail and medullary cavity. We have a nail translation along the interlocking screws. In the plexiglass model, we have three screws here, but still we have a significant instability, and the toggling is due to the manufacturing tolerances which are necessary in order to avoid that this or enables these screws and nail fit, even if there are tolerances at the higher end. So how does the polar screws work? Let's have a look on how an oblique fracture is axially loaded, where we have a discrepancy between the inner nail between the inner bone diameter and the outer nail diameter. When we load it, we slip and we have shear forces, and this results in significant misfit and a reduced contact area. But when we place polar screws, and we always place them on the blunt side of the blunt angle. When we now load the construct, we hit the other fragment, but there is no displacement anymore. Instead of shear, the bad shear, we have a good compressive force, and we have 100% contact area. So here in the plexiglass model, we end with a good contact. And these are it's a necessary requirement for alignment and fracture healing. So polar screws can reduce the diameter discrepancy, prevent translation along the screw, increase contact area, and transforms the bad shear into the good compression. Polar screws can correct and maintain the alignment, increase the primary stability, enhance the nailability, but they require usually additional radiation. There is a risk for potential nail damage, and it requires some knowledge of pathobiomechanics, so it's worthwhile to sit down and draw before you place, because it happens that they are on the wrong side. They always need to be on the blunt side. What can we use as polar devices? Actually everything which has a resistance and is stiff. It can be, in terms of timing, can be done before and after nail insertion. Temporary or permanent, different diameters and different stiffnesses can be used in order to adapt the process of aligning. Locking bolts, screws, K-wires, nail, even bone cement, for example, in order to steer for a chosen nail entrance. So let me summarize. Nailing of proximal tibial fracture, always a challenge. Positioning and starting point, always crucial. Understand the pathomechanics of the tibia, the deformity rules. It deforms to the higher side of the fracture line. Apply to approach and fixation, and analyze the problems early rather than late. Additional tools can be plate, X-fix, polar screws, and other things. And usually it's not the nail which is a bad boy. It's a lack of planning if we are facing non-optimal results. Thank you very much for your attention.